Okay, Dean, floor is yours.
Okay, I'm going to skip going over my background because I'm assuming that most of you have probably sat in at some past time when I've gone over what I did in past years and everything. So I'm just going to launch into this a little bit and also invite you to, interrupt me and make comments as you want, or put a questions or whatever in the chat box. So um, this is a big subject. I may have even talked about this on one of these trainings before in the past year or two, but this is kind of like a subject that really never gets old here, because there is always going to be a concern and an interest for what to do about kids who have been seriously abused or neglected, a lot of times abused or neglected in multiple ways. Um, and about the extent to which they can recover normal development, the extent to which they can have good lives, and what we need to do to facilitate all of that stuff, which for me is very much as much of concern in child welfare as issues around safety issues. So, in recent years, there's been, both in this state and other states, a desire to focus as narrowly as possible on child safety, even defined in this state as physical safety in the Keeping Families Safe Act. But when you talk about kids thriving in their lives, of course, we're talking about a lot more than just being safe. And by the way, being safe and feeling safe are not the same thing. I mean, to kids. So this is one of these dimensions around the whole subject of safety that we need to keep in mind here. It's one thing to say that kids are objectively safe. I mean, a lot of times that's arguable, but sometimes we kind of know what we're saying when we say that. That doesn't necessarily mean that kids who are deemed safe feel safe. That's something else. And feeling safe has everything to do with the ability to recover, particularly from trauma histories, as we're going to talk about here, right? So resiliency in the literature, and a lot of times there's been a lot of this, a lot of research on this in child welfare, but a lot of it in other fields as well. So this is one of these broad concerns that certainly transcend child welfare, and in mental health, and issues related to kids growing up in poverty. I mean, even issues around kids who are in families that experience divorce. I mean, this is a issue that comes up in a lot of different kind of dimensions here. So the way that the term resilience is often used is, a lot of times it's used to have a couple of meanings. And the first meaning is the sort of people who are immune. I mean, this is kind of an extreme word. The word used to be invulnerable, but kids who are sort of have a high degree of immunity, maybe that's the way to put it, to harm related to child maltreatment. And we'll come back to that in a minute here. And then the more common way, the way we're going to talk about more of this today, is children who can recover much more quickly and much more fully from adversity, including child abuse, neglect, and everything that goes with it. I mean, growing up in families with drug, alcohol abuse, or chronic mental illness of parents, or domestic violence, or all of the above, combined with poverty, and often other things as well. I mean, so it's not going to be news to any of you that we're talking about a lot of really troubled families here. And so the question of what do we do for the kids, not only their immediate safety, not only their subjective feelings of safety, but their well-being in the sense of their ability to recover from whatever kind of emotional and developmental harm that they've experienced there, which a lot of times is very great, as you all know here. So part of this subject that we're going to come down and talk about here just in just a minute, about the characteristics of kids that are associated with resiliency, with high degrees of resiliency. But I guess first I want to talk about the histories themselves a little bit, so maybe some of you remember that after 9/11, there were studies of students in elementary schools in that neighborhood of New York City who have been virtual witnesses to the events of that day. And so, of course, there was concern. This seemed to be an opportunity for some researchers, as they saw it, to really look at how the extent to which kids are impacted by trauma, the extent to which they recover from trauma, and so forth. Well, one of the main, some of these studies were done with pretty young kids. I mean, with kids in the early elementary grades and kids in middle school and so forth. So a range of studies here, and by more than one researcher. And what these studies found pretty much is that there was a surprisingly low rate of trauma as indicated by PTSD symptoms. And again, that's just one indicator of trauma, but it's the one that's the most often used. And so post-traumatic stress syndrome symptoms. And so just to remind briefly what those symptoms are, the four classic symptoms: intrusive memory, sometimes that occur as nightmares during sleep, or also as intrusive memories, almost like flashbacks during the day. States of hypervigilance, extreme sensitivity to stress, constantly scanning the environment for threat or for sources of threat. That would be one of the classic symptoms. Feeling numb, having no feelings at all, or no feeling at all much. That would be a common one of the PTSD symptoms. And of course, finally, dissociation, sort of standing apart from oneself, viewing oneself as as an object to be seen or viewed rather than as an agent, someone who is controlling their choices and whatever. So these four classic symptoms being used as indicators of trauma there. The rates of trauma in those studies was, somewhere in the 10 to 20% range in most of the studies. It was really, a surprisingly low fraction of the kids. And there were also a number of studies. Well, what happened to those kids? I mean, the ones who got into treatment, the ones who didn't get into treatment, what was the primary sort of difference in what were the predictors of recovery? And maybe this is going to sound almost too common sensey, but it really had more or less to do with the quality of parenting. I mean, the kids who had good, strong parental support and very concerned, involved parents, they got over if they had PTSD symptoms. Many kids didn't at all, but the ones who did got over it a lot quicker than the ones who didn't. And so not a surprise to find out that the quality of parenting has something to do with the extent of resiliency, right? So now the reason this study is important, obviously this was a huge event in American history. I mean, this was and it would be a huge event in the lives of these kids. I mean, they would sort of never forget where they were that day, what they saw, and so forth, right? But it was also a single day with a couple of major events there, right? In the aftermath of those events. When you talk about abuse and neglected kids, we're talking a lot of times about chronic abuse and neglect, something that doesn't happen on just one day. I mean, it happens chronically over some period of time, and then also a lot of time kids experiencing multiple forms of maltreatment. That is, being both abused and neglected, either physically abused or sexually abused and neglected, almost always neglected. And then, of course, once you have the chronic histories, you always have, and I want to underline the always here, you always have a component of emotional abuse and neglect and chronic maltreatment. That's not always true in acute, serious instances of maltreatment. It's not always true that there's psychological components to that. There often are, but it's not all a 100% thing. But once you get to the chronic cases, it is a 100% thing, right? So now you have kids a lot of times who've been neglected, physically abused or sexually abused, and they've been emotionally abused and or neglected as well. And so, and that has occurred chronically. And furthermore, so that's chronic trauma. And furthermore, the phrase complex trauma is used to refer to trauma that originates in caregivers. That is, it's not only that the kids were traumatized, but the people who traumatized them weren't strangers. They were intimate people. They were parents or caregivers. The very people that kids would trust, supposedly trust to keep them safe, were the very people who had mistreated them in very, very serious ways here. And so, so obviously that is going to create kind of issues around development. So it really matters a lot here. Before I get off this history thing, I want to emphasize some of the implications of this here, right? So you end up with about 1/5 of kids in this state who go into foster care. Now I'm talking about not all kids in foster care. I'm talking about entries into foster care in any particular year. About 1/5 of those kids are infants in the 0 to 1-year-old age range. About half of those infants come into care in the first 3 months of life. Okay, some of them, maybe this is less true after the last year or two with changes in legislation than it was before. I guess we're going to, because there has been a reduction in entries into care of infants. But I guess what I'm trying to say is that there's a group of kids who come into care, some very young kids, who don't really have maltreatment histories or not much of one, either because they were removed from the home before it happened based on risk only kind of thinking, or it may have happened, they may have had good early childhoods, and then something happens when they're just a little bit older. I mean, as someone else, the mother becomes involved with a new partner who's violent, or all manner of things can happen. But there are some children who have good early histories, and then they go on to be seriously maltreated kind of kids. But nevertheless, they have the good early histories. So it just turns out that one of the factors in resilience, the ability, and here I'm focusing mainly on the ability to recover from adversity. One of the main issues there is the extent to which kids have developmental assets. And so, and by that means that some of the very important things that need to happen in early childhood have happened for those kids. So for example, they may really have developed very positive, secure attachments to caregivers. That would be a developmental, maybe the best, a trusting relationship in the first year of life. That might be the best, the most important developmental asset there is for very young children. And it's hard for kids to do a lot of very positive development if they don't have that particular asset. The development is going to be very, very difficult for them for a variety of reasons that I'm gonna discuss here, right? So I guess what I'm saying is there's a whole range of experiences here that maltreated kids have. And that has to do with the timing of maltreatment. That is, at what point did it happen in the child's life and in their development, and what had happened to them before that event or events occurred. I mean, to what extent had they had a process of pretty normal nurturing care before they were maltreated, or had they never had any experience of that at all? Have kids never had any experience of actual nurturing care in their entire lives, right? And so that is going to, so the history of maltreatment, the extent of it, how chronic it is, who exactly did it, over what period of time, whether kids have, all of those issues are going to figure into the resiliency kind of equation here. And so, and then one other point I want to make, and then I'll stop and give you a chance to ask comment or questions before we go on here. Well, I kind of lost my train of thought here. So maybe we'll just go back. Maybe I'll just stop here. Oh, I guess what I want to say is that in the literature and the studies, particularly the ones in recent decades, most of the emphasis in the theory of resiliency has been that resiliency is the norm. It's not the exception in child development. That is, there used to be the idea that kids who, really could bounce back from profound adversity, there was something extra special about those kids or something. There was something that maybe it was even genetic. Maybe there was even some strong genetic differences there between the kids who were the more resilient and the less resilient kids. But in the studies in the last decade or two, the emphasis is more on the theme that resiliency is the normal state of affairs. That is, the ability to bounce back from adversity. That's the normal state of affairs. And kids have it to some degree or other, but it's not a special miraculous trait. It's not something that depends on a special gene or some combination of genes or something like that. it's sort of built into human development that human beings have the ability to overcome adversities here. Even very, very young kids do, particularly if they get the right kind of help here. So before I go on here, I'm going to stop here and see if you have comments or questions here.
Yeah, can I ask something?
Mhm.
The documentary Katrina's Babies spoke of, specifically to how children were affected and what their lives looked like during and after Katrina. And the discussion about resilience in that documentary, basically, one of the comments was, no one from the outside gets to determine an individual's trauma and how they have been resilient to it. That is solely for the individual affected to determine. And what happens in resilience, and the buzzword of it, is it removes the need for a society to change what they're doing, because if you place the recovery of that these individuals are resilient, you don't address what we need to do differently as a society, that we even place individuals in these kinds of situations they have to be resilient to. And I just feel like, for me, watching that documentary and seeing those kinds of views was important, because it becomes a phrase in which we as a society get away with doing little to change what we're doing wrong. So that's just what I want to say.
Thanks. Yeah, I want to add just kind of one more thing on that, is that there is quite a bit known about the nature of adversities that kids, I mean, putting aside, for example, all the social structure issues here and all the issues related to poverty and deep poverty and racism and structural racism and oppression and income inequality and all of those things that we know are true of our society. I mean, there really is a whole body now of science and literature on the adverse childhood experiences stuff around adversity. And of course, that has to deal with things that we're familiar with in child welfare, growing up with chemical dependency, with domestic violence, with chronic mental illness, and with the loss of a parent. That could include foster care, that could include divorce, it could include death, abandonment, or whatever at an early age. Growing up, particularly emotional abuse and neglect, are huge factors in adversity for kids, right? And so that now there have been, even within the last couple of years, there have been a couple of studies that have found that the annual mortality rate associated with rates of adversity, these adverse childhood experiences thing, that's based on a retrospective kind of survey that people do of their own kind of background and lives and so forth, and people give themselves, in effect, scores. I mean, all of you can do the same here, but it's really children and adults who have scores of 4 or more. That's maybe, depending on the study involved here, that might be anywhere from 10 to 15% or so of the population. It's those people who are just loaded up with the adversities that really have the most challenge and struggles, as one might expect, with issues around social development and emotional development, and with issues around, are they going to be able to thrive and survive in the society here? And this is not to say by any means that everyone is the same. I mean, that isn't the message of the adverse childhood experiences studies. It's just that if you look at large numbers, at large samples, you're going to come out with some kind of averages here. So the higher the adverse childhood experiences score, the more profound the effect on health and mental health over the lifespan, not just over childhood, over the lifespan. And those effects include higher rates of early mortality. So that is very documentable. I mean, so lower lifespans, that means something pretty concrete. And of course, the sort of the explanation for why early childhood adversities have such experience, have such effect on people over the lifespan is because at some point, everyone comes up with strategies or ways of coping with those adverse childhood experiences. Saying, well, it just turns out that people who have very high scores tend to pick very dysfunctional, a lot of times on average, very dysfunctional ways of coping with the effects of those adversities. And so that is, so ways of dealing with depression that might involve the overuse of substances. I mean, highly reckless behavior would be an example. I mean, issues around sexually reckless behavior, that's all of those issues are a part of the effects of the adverse childhood experiences study. So a lot of effects on health and mental health really across the lifespan, based in a dose-related way on the number of adversities in childhood. And remember, so, and those are, and those surveys, for the most part, they're not even counting poverty in that. I mean, so this has got to be an underestimate of the profound effects of adversity here. So before I go on here and talk a little bit more about some of the other aspects of particularly disturbed early development, let me stop here and give you another chance for a comment or question here. Okay, so what I want to do here is talk a little bit more about, well, what are kind of the correlates, and particularly talking about the kids for whom abuse and neglect starts very early in their life, maybe on the first day of life. Sometimes it might start in infancy, it might start when they're a year, 2 or 3, and to the point where those kind of experiences affect their ability to trust adults, particularly to trust their caregivers, right? So what can we expect to happen to those kids? And particularly from a trauma standpoint, the single most probably concerning, the most impactful, there are many of those, many impacts here, but the one I want to emphasize the most is the problem with emotion regulation. Because the ability to regulate one's emotions has everything to do with the ability to survive in social institutions such as schools, the ability to have friendships, the ability to function at all as a self-sufficient kind of person in society depends to a very large extent on emotion regulation. And so that is what is undermined. It is that capacity that is undermined by early trauma. And so, I mean, maybe some of you have heard me talk about the Bruce Perry book, The Boy Who Was Raised as a Dog. Some of you may even have read that book. I mean, that book came out in 2007, something like that. If you haven't read it, I recommend it. I mean, it's written for non-experts. It's a series of chapters and stories. And the book takes its title from one of the chapters, this 6-year-old boy who Perry encountered in an emergency room in a Bay Area hospital when he was an intern. And Perry is a trauma expert who ran a trauma center in Texas and still does, I think. Anyway, he is brought in for a consult on this little boy who's in a cage in this Bay Area emergency room. And this little boy is down, he's called in by the nurses and docs because they can't manage this little boy. He's in this, they actually have him in a cage and he's naked and he's covered in food and feces and he's on all fours and he's throwing food and feces at the docs and nurses and everyone else who walks by him. And he's uttering, he doesn't have speech, he doesn't have language, he's uttering guttural kind of sounds. So, I mean, really some extreme behaviors. And what the docs think and the nurses think is this kid is just genetically something wrong there with his brain and he needs to be institutionalized, etc. So anyway, they call Perry in for a consult. But before Perry does anything else, before he's going to go along with a diagnosis like that, he does something that they hadn't done. And when I had caseworkers, I go over this scenario with caseworkers in neglect training a lot. And I ask them, well, what's the one thing? What's the thing that Perry did that those other experts in the emergency room had not done? So maybe I'll do the same with you. What do you think the one thing is that Perry did that the docs and nurses had not done? And trying to understand what was going on with this little boy.
Open the cage.
He eventually does that, but that's not what he does initially, because again, think for a second why this is this little boy, 6 years old, why is he acting like this? Why is he throwing food and feces and screaming and yelling at everyone who walks by the cage? What's the underlying emotional state of this little boy?
Fear.
Yeah, terror. This boy is terrified. This little boy is defending himself in the only way he knows how at that point in time. So, and at some point, obviously, Perry is going to try to establish some kind of relationship with this little boy, but that's not what he does first. So again, I'm going to, one more opportunity here. What does he do first? So standard medical practice, and this would be true in mental health, would be true in medicine as well. What he did that those other docs and nurses did not do is he took a careful early history. Paper and pencil, careful early history. He wants to know from people who know the boy, how did this little boy get like this? And that is a question that we can ask of anyone of any age who is exhibiting really, really extreme behavior. What happened to allow this behavior to happen? How can you have a 6-year-old who doesn't have language, who can't stand up, who's naked, who's covered in food and feces, and how can that even, how is that even possible? And so what Perry finds out is that this boy was born to a drug-abusing mom who abandoned him when he was a couple of months old. He lives with a grandmother till he's about a year old. She dies. He ends up going to a friend of the grandmother's who turns out to be a dog kennel operator. He spends the next 5 years, most of the time, in a kennel during the day and, you know, in the proximity to dogs. And so he has a funny way of sniffing. If any of you've read this book, you know, it really very distressing to the nurses. He sniffs like a dog and so forth, right? He's been in proximity. So as soon as Perry has his history, he understands probably this kid isn't genetically brain damaged. This kid hasn't been socialized. This kid had been severely and chronically neglected, profoundly, in multiple dimensions. So at that point, Perry isn't going to go along with the diagnosis. So at that point, to try to establish a relationship with this little boy, he stays several feet away from the cage. Remember, the little boy is scared to death. He stays several feet away from the cage. He takes a bit of a muffin. He models eating this muffin with pleasure. Then he takes some of the muffin, he throws it into the cage. And ultimately, the little boy, remember the little boy, why does Perry do this? Because the little boy is starving to death. Perry understands that. So he throws some muffin into the cage. The little boy eats a little of the muffin, so he starts to associate Perry with pleasure. So then Perry throws a little bit more of the muffin into the cage. And finally, he can get down on his hands and knees and he can approach the cage closer because now the kid is associating him with food, right? And so at that point then, once Perry is able to be in the proximity of this boy without this boy freaking out, then he has the boy taken out of the cage, put into a quieter room with less stimulation, with fewer nurses and docs who are interacting with him on a daily basis, right? And so at that point, within a day or two, then they're actually able to get this little boy into a shower. They're actually able to, you know, to clean him up. He pretty soon, within a few days, he stands up. He starts to utter sounds that sound like words. And so, you know, within a couple of months, within 2 to 3 months, the short version of the story is that this kid goes into foster care. And Perry says that he had never seen a boy who was as feral as that, as unsocialized as that, be able to recover as quickly as this little boy did. But he was able to recover incredibly quickly because of what? And I've already told you the answer. Why was this little boy able to recover, this little boy unsocialized for 5 years? Why is he able to recover as quickly as he was able to recover?
Because he had a fairly good early history.
Yeah, he had a nurturing grandmother for almost a year. He had the best developmental asset a little kid can have there. He had a nurturing caregiver for almost a year. Right. So that meant that he's able to form relationships with people. He has that capacity. So occasionally caseworkers then, when I tell them about this story, sometimes they'll ask, well, what if he didn't have it? What if he didn't have a nurturing grandmother for the first year and this was just the way he had been raised and so forth? Would it be hopeless? Would we be unable to help this kid at all? And of course, what Perry's answer is no. We can always help kids. It's just going to be a lot harder. It's going to be much, much more difficult if a kid doesn't have those early developmental assets, right? And particularly the one about being able to form relationships with caregivers. So the end result of this story is this kid goes into foster care, and then about a year later, the kid writes Perry a message. Thank you, Dr. Perry, you saved me. And Perry writes the words at the end of the chapter, I cried, right? So, but anyway, the theme of this story is that this kid was able to make a phenomenally quick recovery because he had the super most important developmental asset there that there is, right? And some kids who are in child welfare have this kind of early history, which is very, very positive. Many of them don't. And for many of them, it's going to be a lot harder, right? So, and for the kids that don't have this developmental asset, they're like the kid in the cage, the boy in the cage, they are going to have issues with emotion regulation. Well, what does that actually mean? It means that they are going to be super, super sensitive to stress. They are going to have issues with tantrums. And at the very extreme end, that the word for those tantrums is meltdowns. And this is, by the way, children with trauma histories. This is kids of all ages. This is little kids. This is young school-age kids. It's kids who are delinquents, right? And so a lot of the caseworkers that I have done training with over the years, many of them come from juvenile justice. Some of them worked at Echo Glen, places like that, or they've been other kind of places. They've worked in residential care facilities with teenagers, and they've actually been through this experience where they've had to participate in, sort of holding, sort of some kind of restraint with a kid who's in a meltdown. And if if you've ever had this experience, some of you may have had it. I mean, a meltdown's really extreme. I mean, kids bite, scream, scratch, spit. If they have language, they say ugly, horrible things. I mean, and so, because they're just in a freak out kind of mode here. And so for kids to be, so the reason I'm stressing this so much is that because emotion regulation is one of those developmental assets that if people don't have it, if a young child doesn't have it, they are going to have a lot of trouble in managing the school system. They're going to have, as they get somewhat older, people are going to be really, really afraid of them. And the nurses and the docs with this little boy, the 6-year-old boy in this emergency room, they were already very, very afraid of this little boy when he was 6. I mean, he wasn't 50, 60, 70 pounds. He probably wasn't even as much as that. And they're already afraid of him. What if he's 180 pounds and he's 14, where he's really able to hurt someone? So the emotion regulation issue is super important. So when we talk about, for example, particularly with kids who have histories of early trauma and who have a lot of trouble in feeling safe. So this is sort of the message from the Perry book and so forth, that kids who have trauma histories, before we can help them, they really have to feel safe. And that's, by the way, also true of adults. So they have to, so for Perry, what that meant was moving the child to a room with less stimulation, And so part of what it helps for young kids to feel safe is to have a very predictable structure. So the best single book on this particular subject that I've read that I think is useful for foster parents, and I think it's useful for CASAs and for caseworkers, is the Deborah Gray book, Nurturing Adoptions. So, and Gray has written a number of books. Gray's a therapist who I think still lives in Bellevue, and she's retired within the last year or two, but she's written a number of books on adoption and on related subjects. And the material in that book is just as good for foster parents and for birth parents as it is for adoptive parents. So I asked Gray one time, I've gotten to know her a little bit over the years because I'm so positive about her book and everything. And I asked her, well, why does this book have this title? And she said, because the publishers insisted on it. She said that they said, well, adoptive parents might actually buy this book, whereas they didn't think, other groups actually would. But, material in this book. So the material in this book is very developmentally focused. That is, for a 1 or 2-year-old, what do you do to help a kid to calm down? For a 2 to 3-year-old, for a 3 to 4-year-old, 4 to 5, on through the age range up to age 17 or 18, what do you actually do to help kids to, one, to feel safe and to be able to gradually be able to self-regulate? And so initially, people or professionals, foster parents, caregivers are going to have to help kids to regulate themselves because they don't have that capacity. That's been what their maltreatment history has done to them. And of course, if they go into foster care and then the foster parents aren't able to manage, and a lot of times they aren't, if they're not able to, if they don't know what to do, and they may make it all worse, and then the kid goes from one home to another home to another home, I mean, the kid may end up, worse off after years of foster care than they were when they went into foster care, if people don't know particularly how to deal with this particular challenge. And this is so, and I want to stress again, this isn't the only challenge having to do with resiliency or with recovery or with treatment, but it's the essential one. It's the one that kids really do have to deal with and overcome in some way if they are going to have halfway normal development within a school system. Kids who cannot control their behavior within a school system and who, peers can cause them to freak out by looking at them the wrong way, can't manage their behavior, hit other people, hit teachers, hit peers. Those kids are headed for institutional kind of environments. Or, they're not going to make it through a school system. So this is why this particular set of concerns and skills and challenges is for the very extremely maltreated kids. This is the one where trauma-informed systems have to become adept at. And trauma-informed has become, to me, kind of like an kind of overused word, still useful, still describes something, but concretely, what it is that we're trying to get at here. How to help kids to feel safe enough so that, and in the way this kid, by the way, the 6-year-old in this Bay Area emergency room, once this kid felt safe, he could actually receive the services that were already available within the hospital setting. He didn't need some special, whole group of new services that no one ever thought of. He needed the services that the hospital already had. He just had to be able to receive those services. He had to feel safe enough to receive those services. And that's true of a lot of the kids that we have in foster care. So those kids, to be stabilized in care, someone has to be able to deal with this emotion regulation kind of issue here. So let me stop here and give you a chance for comment or question before we go on here. I do want to say that over the last 10 to 15 years, a number of school districts have really been able to have done lots of training in trauma-informed work. I think in terms of possible investment in trauma-informed practice, maybe the schools have done more than child welfare has done, but this is probably an area where, I left child welfare in 2004 in Washington, went to the University of Washington and so forth. I would say the way that the system is different now in a positive way than it was when I was in child welfare is that so much more is known about trauma-informed care. So much more is known in ways that are accessible to people. So the potential for really helping kids who have these kind of histories is so much greater than it used to be. It's just that we really have to make an effort to make sure that knowledge is used. So I guess I want to mention a couple of other things here that have to do with issues around foster parenting, because the foster parents have a very big role to play here. and particularly in understanding, because again, the developmental challenge, just to repeat this, for the kids who have these, serious early maltreatment histories is they need to learn to use adults to calm down. So I want to say that again, that's a sort of a function of attachment. It's a function of the early caregiver, infant normal kind of relationship when it's a positive relationship. Parents help kids to calm down. That's the sort of the skill, so to speak. That's the emotional ability that many of the kids in foster care who've had these early histories lack, and that's what they need to be able to regain here. So it's very helpful then for foster parents to know something about attachment styles. And so here I want to say something just briefly about this, because again, foster parents can do so much good here and they can do so much harm depending on the mindset that they have here. Because even kids who have very early experiences, very, very negative experiences with caregiving, and come into foster care with insecure attachments or with, disorganized attachments, they can really gain the ability to interact with caregivers in positive kind of ways, but the caregiver has to know what they're doing here for that to happen. So let me give an example here. So you end up with lots of kids who come into care with what I've described as insecure attachment styles. And by the way, you can't tell what a baby's attachment style is until the child is about 12 months old. There's, so by the time that a child is 12 months old, a child has a survival strategy, and that's what an attachment style is. It's a survival strategy. So for kids who have insecure attachment, what that means is they simply don't trust caregivers because of their early experiences. So when a kid, for example, who is learning to walk falls down and hurts themselves, what you would expect a child who has had positive experiences in the first year of life to do is to go to a caregiver for some kind of encouragement and for reassurance and for affection. Some kind of touch is going to help them to calm down. A kid who has insecure attachment experiences, a lot of times they're going to isolate themselves. They may go to their bed and put their thumb in their mouth. They may simply not cry at all. And so it's very easy, I think, for foster parents who don't know anything about this subject to imagine that kids who aren't coming to them for reassurance or for help or for affection, or kids who are sort of not crying at all, or they're little stoics at 18 months old. So somehow that's a positive developmental experience when of course it isn't. It's development that's gone wrong. And so what you want in that situation is for a foster parent or a caregiver to reach out to the child. If the child doesn't reach out to the caregiver, you want the caregiver to reach out to the child. Why? Because you want the child to learn to use adults to calm down. That's the developmental challenge for maltreated kids. That's it. And if they can't do that, they're going to come up with all kind of dysfunctional kind of strategies for coping with pain, for coping with insecurity, for coping with anxiety. That all these dysfunctional strategies have to do with alienating other people, with pissing other people off, with making other people afraid. And so as they get bigger, they're going to be more successful at that. So in order then for the resiliency process to occur, there has to be a focus on this issue around emotion regulation, a child's growing ability to, to not engage in meltdowns. So first, they are going to engage in meltdowns a lot of the time. So gradually how to stop that, how to make it less, gradually how to give kids the ability to recognize their triggers, to be able to stop themselves from doing that. And so what trauma-informed care then is a whole bunch of skills and strategies for allowing this kind of developmental challenge to be overcome. And that to me is sort of the key issue with resiliency, with recovery for the kids who have been seriously maltreated in their early childhoods, from infancy sort of on there, right? It's that one. So let me just stop here and see if you have, going to run out of time here. So I want to cover a little bit more material here, but I'm going to stop, give you a chance for a comment or a question here. Okay, so the best single summary that I know about adversity, and a lot of, I want to say this again, a lot of research on this particular subject. But the best sort of summary that I found, the most useful summary, is in Judith Herman's book, Trauma and Recovery. So if you haven't read that book, I highly recommend it. It came out in 1992, 1993. So it's over 30 years old. It's still, in my opinion, the best book in trauma, which is amazing because there have been a lot of advances in the understanding of trauma in recent years. So it's a truly classic, great book. But in that book, Herman has a chapter on her work with Vietnam veterans. And so this book was written, she wrote this book in the 1980s. And so she worked with a lot of people coming back from Vietnam who had been in combat and who had classic symptoms of PTSD and so forth. Well, what did so she found what I said earlier, a lot of these veterans got over it and pretty darn quickly. And there are, by the way, a whole wealth, a multitude of evidence-based programs for dealing with PTSD. This is somewhere in the last 30 years, tremendous advances in knowledge here. And so what Herman found then is that for the combat veterans who recovered pretty quickly, they had the following assets. They had the ability to join with others under conditions of danger. So I'm going to say that again. They had the ability to join with others, no lone rangers among the resilient group. So where did they get that capacity? Arguably, they got it from their childhood experiences. They were able to form positive relationships with people. They had that developmental asset. They had the ability to control their emotions. Again, the sound familiar. They didn't go berserk in combat. They didn't torture enemy prisoners. They retained some sort of moral foundation in war, which is a very, very difficult thing to do when people are trying to kill you. So they had this ability of emotion. They had this ability of emotion regulation. They were proactive in problem solving. So this is another one of the sort of resiliency traits that comes out in lots of the research studies. People are proactive in response to challenge. That doesn't mean that people always do the right thing or that they're smart or that they're skilled. It doesn't even mean that they're skilled. It just means that they're proactive. They don't lie down and take it. They're not passive. They don't give up quickly. You know, that if they fail at one approach to solving a problem, they try something else. They don't give up. So when I do training, for example, on chronic neglect, and one of the issues here is that one of the characteristics of chronically neglected kids is they are the least persistent in problem solving of all maltreated kids. That is, they are the quickest to give up in the face of difficult problems that they can't solve, right? Or that they have difficulty in solving. So being proactive, being able to take initiative, doing things on one's own behalf, what I call in training self-efficacy, being able to do things on one's own behalf and on behalf of one's kids. So that is a resiliency trait. And finally, for foster kids, and I can't emphasize this too much, they need some take it to the bank, socially valued skill or capacity or characteristic. So I'm going to say that again, because this is a troubled group of people, of kids, and they're going to be a troubled group of adolescents and a troubled group of adults. They're going to have interpersonal difficulties their whole entire life, and that's best case scenario. So they got to have some basis for getting some positive social support along the way here. So some kids might actually, despite all their bad experiences, they might do well in school. There might be kids who are super good athletes, kids who are talented musicians, good artists, kids who are good at farming or good at cooking, something. They need some skill that is socially valued in the community and the society where they live that is going to bring them some positive input from people. So this has direct practical application to kids in foster care. It isn't just a matter of getting them good, safe caregiving and referring them to whatever mental health program is around to deal with their mental health issues. That's a minimum agenda. That's not enough. The kids are going to actually need to acquire some kind of socially valued skill, because a lot of these kids are going to have real difficulty in school systems. I mean, serious difficulty. and even getting through school at all, much less in doing very, very well in school. So they are going to need a lot of times, some other kind of skill or capacity, a whole range of things. And so we need to be doing for the same thing for kids in foster care that we do for our own kids and for our grandkids. I mean, you talk to any upper middle class family in this country and who have school age kids. And, I have two kids. I have a grandkid now who's 9 and one who's 7. And their parents just spend time on weekends, and they're busy people. They both have jobs. On weekends, they're going to basketball games, soccer games. They're taking the kids skiing. They're going to gymnastics. They're going to swimming. They're just doing all kind of things to give the kids skills. Those skills are going to help them socially. They're going to help them with self-confidence. That's what upper middle class families, this is a way of passing on privileges. So that's, again, what we do. And an enlightened foster care system, by the way, one idea that a foundation should pick up on, put $250,000 out there in a state the size of Washington and give $5,000 to $10,000 grants for talent development and pick 15 to 20 winners a year, 25 winners a year. Have people apply for kids who are in the foster care system based on the development of a talent. They've already showed some indication of a talent, whether that would be in music or in computer games or in athletics or whatever it would be, and give them and recognize that talent and give them some money to develop the talent. Just doing something like that to show we care about your future. You have a future. You have all kind of potential. We're willing to find things that you're good at. Now, what happens to kids who are not good at anything and who are also failing in the school system? A lot of those kids, by their teenage years, they become good at something antisocial, such as violence. So nothing is more adverse to development than that particular developmental trajectory. Failing in school, becoming good at violence. That's a person headed to the prison system. That's what we don't want to happen here. So a lot of I think the mysteries of resilience, a lot of times, I think we understand it better than we used to, but it isn't like a hugely complex, difficult thing to understand here. We want kids to be able to form positive relationships with people, both with caregivers, but we want kids to actually be able to have friends. That's a key factor. That's not a mental health diagnostic thing, but in terms of whether kids are really resilient or not, that's a really good, simple question. Do you have a close friend? Do you have friends at all? And if the answer to that is no, that is a kid who is on a bad developmental trajectory here. We want kids to actually be able to negotiate the school system. To do that, again, they have to have the ability to control their impulses and emotions to some extent or other. And there's a whole bunch of evidence-based programs for helping them do that, a whole wealth of material that we can also be giving to foster parents about that. We want kids to be proactive. We want kids to show initiative, to be curious. Curiosity is tremendous strength, is tremendous sign of emotional health. So for even kids who have very disturbed histories, and this would be true of adults as well, curiosity can save those kids. And that doesn't mean that they have to be brilliant. They have to be curious. And whenever we see kids are curious about something, we need to be jumping on that and reinforcing that and rewarding that. It helps to have skills. I just cannot say that too much. That is a source of self-confidence for kids. It's a source of self-esteem. It's a source of social self-esteem, right? So those are the areas where we need to be focusing and helping kids to actually develop what we call resiliency, right? They're going to need some social skills. They're going to need emotion regulation abilities, right? They're going to need to be able to show some initiative. We want them to be curious. And we want them to have hope about their potential, right? So those are the things that are going to be helpful here in terms of a sort of a whole range of outcomes, both in childhood and adolescence and in their adult life as well. So let me see, it's 3 minutes after 12, so I run out of time here. So let me stop in here and see if you have a comment or question here.
I have a comment, Dee.
Okay.
I agree with everything you say. What I'm looking for is what I can do as an advocate to help with this. And it came to mind, I met an advocate once who said that every time a child moves, one of her children has to move, she fills out a form of all of their talents and strengths. And she'll sit with that new foster home and talk about that. And I had kind of forgotten about that until recently. One of my kiddos is in a great foster home right now. And I mentioned that he was really good on the skateboard. He's like 6 and the kid's amazing. But he'd been in that home a year and they didn't know that. And I
Yeah.
assumed the child would have said something, but he's just so used to losing things, leaving behind things. He just didn't talk about it. So, and I also think it would be really great if we said all these positive things in front of the child in that new home. There's just really work hard to find the positive, because this little guy has a lot of big behaviors that are difficult. Anyway, that's just what I
Yeah,
want.
thanks. I agree with that. And then just one last thing that I want to say here, just in terms of a sort of a strategy for how do you take kids, and I don't mean just foster kids. I mean, sometimes it can be our own kids or kids we know or kids in school. How do you take kids who are difficult to manage and control, who have oppositional behaviors, who lie and steal, and, they defy adults? And how do you take kids like that and change their behavior into mostly positive behavior where they become a manageable child? And you want the one principle and answer that every evidence-based program developed in the United States uses. You know what that principle is? More reward than punishment. Those kids, you have to find ways to praise those kids more than you punish them. It is changing the ratio of praise to punishment. And so you have to have something. So again, you have to have caregivers and people who interact with kids who are alert to that principle, right? Because at some point, you can't ignore some of those negative behaviors. At young ages, a lot of times you can ignore the negative behaviors, but as kids get older, you can't ignore them. You got to manage them in some way. But at the same time, kids need to be getting positive rewards as well. And there needs to be, and the higher that ratio is of reward to punishment, the more likely it is that you're going to be able to take an oppositional kid who's just impossible to manage in any situation and make them into a kid who is a pleasure to be around. It's how to do that in a skilled way. And that's what the evidence-based programs, not just the trauma-informed, but all the evidence-based programs around parenting, coaching, and whatever, that's the principle they actually use. I have, by the way, last thing to say is here, I have a list of resources here on trauma-informed care. Maybe I might have sent it to Ryan before, but I'll do it again. If not later today, I'll do it on Monday. I'll send it to you. There's a lot of really good information out there, very, very accessible information. So, I'll send it to you and I'll send it to Ryan. Ryan can send it around. So, thanks. I think with that, I'll stop there.